All right, go ahead.
Okay, so we're presenting on EMTALA, and I'm Sierra Long, and the other person is Nick Lee. Okay, we're going to start out with what is EMTALA. So EMTALA stands for the Emergency Medical Treatment and Labor Act. So it's a law that requires anyone going to an emergency department to be stabilized and treated regardless of their ability to pay or their insurance status. So basically saying that if you go to an emergency room, they have to treat you, and they can't ask your insurance status or how you're going to pay or anything. They have to treat you first. So an emergency, according to EMTALA, is a condition manifesting itself by acute symptoms of sufficient severity, such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health in serious jeopardy, serious impairment to the bodily functions, or serious dysfunction of bodily organs. For example, if you're pregnant and your water breaks and you go into the emergency room, they have to deliver your baby. So that's what that's saying. So the history of EMTALA, so EMTALA was enacted in 1986 by Congress as a part of the COBRA Act of 1985. So in 2000, Congress made EMTALA enforcement a priority with penalties more than $1.17 million, which is a lot. So in 1986, two articles came out about the extent of patient dumping in Cook County Hospital in Chicago, which this is totally crazy, I think. So in 87% of the cases, they were transferred due to lack of insurance, and only 6% had given written consent for their transfer. 24% of those patients transferred were in an unstable condition. It was then concluded that these transfers were done primarily for financial reasons and that it jeopardized the patient's health. So that's pretty crazy because, yeah, it's pretty self-explanatory. But 87% of the cases are transferred due to lack of insurance. So basically they're just transferring people who weren't fully capable to maybe go to other hospitals. And in a different article, it said that some people died because they transferred them when they weren't stabilized, so they didn't make it to the other hospital. Which I think that it's crazy that they would put money in front of patients' health, you know. So these practices were happening more and more often in most large cities with public hospitals. For example, in Dallas, transfers increased from 70 a month in 1982 to more than 200 per month in 1983. So that's why EMTALA went into an act, because they were like, okay, this is ridiculous, you know, we got to do something about that. So hospitals have to follow three main rules when it comes to EMTALA. So the first rule is anyone who comes into the hospital requesting help must be given a screening to see if an emergency medical condition exists. So treatments cannot be delayed to see if an individual has insurance or a way to pay. Emergency departments must have signs notifying of people of this law and their right to this law. So law number 2 is that if there is an emergency medical condition, it must be treated there until it is either resolved or stabilized. If they don't have the capability to treat the condition, they must appropriately transfer the patient, according to EMTALA standards, to another hospital. And number 3 is saying that hospitals with special capabilities must take these transfer patients in. So you can't transfer a patient to a hospital and have that hospital deny them. That's unethical, you know. So why is this necessary? Because this is the anti-dumping law. So basically everything that I've just been saying, it's designed to prevent hospitals from transferring uninsured or Medicaid patients to public hospitals without, at minimum, providing some sort of medical screening, ensuring that they are stable enough for a transfer. Something that's interesting is anyone can be treated according to EMTALA. It doesn't matter whether they have insurance or no insurance, or even if they are U.S. citizens. And so this law allows everyone to be able to get the help that they need, and allows hospitals to not be discriminatory towards anyone. So anyone who's needing help or has a broken bone or is in labor or whatever the case is, they can go to any hospital and know that they'll be treated. So that's just kind of comforting. And then Nick, if you want to go ahead.
Yeah, and kind of just reviewing a lot of this, just the rules that are the entity policies that EMTALA claims. Kind of what Sarah was mentioning, hospitals must have a state licensed emergency room or department. They must get out to the public in some way, advertise that they will provide care for medical emergency without an appointment. And this one I thought the most interesting. It must provide at least 1/3 of all its outpatients for emergency treatments without an appointment. I thought that was kind of an interesting policy there. And also, hospitals are required to have at least one doctor on call at all times, and the hospitals are it's up to them to define what on-call means. I guess there was some discretion as far as what that really means. And it also defines the actual hospital property, any part of the hospital's campus, parking lot, or structure that is providing Medicare. Now, there might be some structures nearby that provide private practices that doesn't count. It's just kind of defining what the campus is. And then talking about the Idaho State Department of Health and Welfare, pretty much the same thing. All Idaho hospitals are required to provide medical screening to anyone in the emergency room who requests such, and required to post signs with rights of individuals with emergency medical conditions or women who are in labor, like Sierra mentioned. They do have rights if they walk in, on their water breaks, like she mentioned. They have to deliver the baby. And they also must maintain all medical records and retain transferred patient records for at least 5 years. And that's it.
Yeah.
All right, great job, guys. EMTALA is definitely an interesting subject. I think it's a good law to have in place. I mean, as Sierra talked a little bit about, a lot of people were dumping. It was 87% of the people were being transferred because the hospital's like, well, I don't want to deal with you because I'm not going to get any money from you, which is sad. I mean, we hope people go into healthcare because they have the desire to help people, to make people better, but unfortunately that's not always the case. But I'm glad you guys covered the fact that it's on the hospital property as well. So if anybody comes on the property, and they're required, if they're in an emergent case anywhere on the hospital property, in the parking lot, it could be like clear out in the farthest corner of the parking lot, they are still required to take care of that patient and provide that care. At minimum, the screening that you mentioned. So, great job. But I'm going to I'll just ask you the questions now. Sierra, what was something that you learned or something that caught you or that surprised you the most about EMTALA as you were doing your studies?
So I thought it was interesting because I knew that there was like some sort of law behind, going into an emergency room. But I didn't realize they weren't allowed to like ask you about your insurance or ask you like, how are you going to pay for this when you go in? I just kind of figured that's like what you see on movies and stuff. But so that kind of caught me off guard. But something else that caught me off guard was that you don't even have to be a U.S. citizen. Like they can literally treat anyone. You can walk into the hospital and be treated. And that to me was kind of concerning, honestly, because they could take like anyone in. They don't have to even check really about who they are, like what's going on. So that honestly was really surprising to me.
Yeah, and if you go into different hospitals or even and this is, I don't think it's necessarily part of EMTALA, but into doctors' clinics, it will mention that we'll take care of you regardless of your ability to pay. So yeah, it's an interesting thing, but yeah, without question, if someone's in an emergent case, you provide that service.
Yeah.
So Nick, same question.
Yeah, kind of what you talked about at the end with the campus. I was really surprised to learn that even if you're on the farthest area of parking lots or in any other structure or something there's an emergency happening anywhere on campus, they are supposed to take care of you. That was pretty interesting. I didn't realize that you actually didn't have to be in the physical emergency room for that to take place. I actually didn't realize that you could be in the parking lot, especially if someone's in labor. You can only get as far as the parking lot. I guess they can gotta help you out anyway. I'm sure that happens sometimes.
Yeah.
And another thing I thought was interesting was reading, especially about the outpatients, or 1/3 of them. It kind of seemed like they were emphasizing that it's important to treat people without an appointment. That they made it a point to make sure that this happens in hospitals. It kind of seemed like they wanted statistics to prove to make sure that they were indeed doing it, that they were indeed taking emergency conditions without appointments. It kind of seemed like they were stressing that be the case for at least a third or something like that.
Yeah, yep, definitely. You want to make sure you have that availability for people to come in if they are having an emergent case, and not have to have an appointment, obviously.
Yeah.
So,
Mhm.
all right, great job. I'm going to go ahead and stop the recording now.
Okay.